Thank you very much, Barbara, for that welcome, and thank you more generally to the NDA for the wonderful welcome and hospitality you've extended to me and to the other sort of overseas people who've come to this conference. I've been really enjoying meeting you all. I'm going to talk a little bit about a big research study that we've completed last year, and I'll just run through what I'm going to talk about. I'm going to first of all talk a little bit about the whole issue of choice and control and how that sits within the kind of policy within England, and some of the criticisms that have been made of policies around that are framed around choice and control. I'm then going to talk about the big study that we've undertaken, which was a panel study. It was a group of people that we followed over a period of 3 years. And I'm going to talk about some of the findings from that study on people's experiences of making choices. And then at the end, I'm going to discuss some of the implications for policy and how we organise services in order to make choice more of a reality for people. So you will know that disabled people have been arguing for 2-3 decades now for the importance of having choice and control. And this quote is from Jenny Morris, who's a disabled writer, English, London-based disabled writer. And I think she spells out very clearly the very strong arguments for having choice. Not just choice, but having choice and control. She says, for those who are reliant on others for assistance with personal care, communication, or how to live an ordinary life, having choice over how that assistance is provided is the only way of protecting fundamental human dignity and achieving autonomy. Choice over how a person's support needs are met is integrally linked to human rights and to the concept of independent living. And Jenny goes on to say that it's not just choice that's important, but it's choice and control. So there's a very strong argument there that disabled people have been making for 20 or 30 years on the importance of choice and control, and how having choice and control is absolutely fundamental to citizenship, to being equal citizens. From a policy perspective, in England, and I want to emphasize that I'm talking about specifically about England, because with devolution, the ways in which policies around health and social care and other kinds of aspects of the welfare state, the ways in which those policies are developing in Scotland, Wales and Northern Ireland are slightly different, and indeed there are discussions taking place at the moment about extending the independence and autonomy of Wales, Scotland and Northern Ireland. So what I'm talking about is only about England. I think within English policy there has been an increasing emphasis on choice and control from a perspective of consumerism. And this was particularly articulated by the last government, and particularly under the leadership of Tony Blair. So there's an emphasis, increasing emphasis, on trying to ensure that in the public sector, people had the same opportunities to exercise choice over the services that they received as they had done in the private sector. And there was a very strong kind of policy discourse that went on, particularly from 2000 to 2010, about encouraging us to think in terms of, to think of ourselves as consumers of services, not just as recipients of welfare state services, but as consumers. And underpinning that was a belief that choice is an intrinsic good in itself, and it should therefore be the dominant factor that shapes the publicly funded welfare services so that these can be more easily, more closely attuned to individual circumstances and preferences. And I'll just quote you from our last Prime Minister, Tony Blair, who said, "In reality, I believe people do want choice in public services as in other services. We are proposing to put an entirely different dynamic in place to drive our public services, one where the service will be driven not by the government or by the manager, but by the user, the patient, the parent, the guardian, the pupil, and the law-abiding citizen." So a very strong emphasis there on choice and consumerism as a kind of ideology that should drive the development of public services. And stemming from that, people have also argued that that consumerism offers the opportunity to remake our notions of citizenship, that we don't just receive services as passive recipients, but that we are, as citizens, actively involved in the creation and the shaping of services through the choices that we make. I've emphasised that that was a policy that was particularly associated with Tony Blair, but I have to also say that the current coalition government is also pursuing that line. There's very strong continuities across government policies. Choice is, of course, also fundamental to the operation of markets. And this is a more long-standing trend within English social policy. It dates back to Margaret Thatcher and the 1980s and 1990s and the reforms that she introduced into the public services, in which we separated out purchasers and providers. And we had a group of people who commission, plan and purchase services, and another set of organisations which deliver them. And of course, if you're going to have markets, choice is absolutely fundamental to the effective operation of markets, because choice promotes competition, it promotes quality, it promotes efficiency. This is the theory. What we have seen over the last 10 years, though, is a shift in the nature of those markets. So that the reforms that Thatcher introduced in the early 1990s essentially put purchasing power in the hands of professionals, doctors, social workers, care managers, who had access to budgets and purchased services on behalf of service users, on behalf of disabled and older people. What we are now seeing is a further shift whereby the purchasing power moves from the professionals to the individual user. And yesterday's seminar, I talked about the development in England of personalised budgets for social care support. And the idea is that by giving individuals control over their own pot of money, they will exercise choice and control over how that money is spent and be able to purchase services with that money that more appropriately meets their needs. So yes, so there is considerable continuity there across different governments, and a long trend over the last 20 or 30 years to try and give people more control and choice over their services. And the most recent example of that is this devolution of responsibility and funding to individuals to make choices about their services. And we have personal budgets now in social care. Personal budgets are being piloted for some groups of NHS patients to buy medical care. Personal budgets are also being piloted for families with severely disabled children and in other aspects of public services as well. And I think one of the workshops this afternoon will be looking at some of those experiences. But choice isn't perfect. Choice isn't a perfect mechanism, and I think particularly for disabled people, there are some challenges in making choice a reality. One of the anxieties that some commentators have expressed is that people have unequal opportunities to exercise choice. They have unequal resources. They have unequal access to information. They have an unequal access to influential social networks. And if you have unequal opportunities, you are likely to have unequal outcomes. So policies based on choice will simply reinforce inequalities that already exist. Another concern is that markets may find it very difficult to respond, particularly to individuals who are trying to exercise choice, for example, through a personalised funding pot, a personalised budget. So there are big questions about whether an individual can exercise the same kind of leverage over providers and get the same kinds of responses from providers as a big purchasing organisation can. People who have very specialised needs may find it very difficult to experience and exercise choice because there may be only one provider or one service that actually meets their needs. If you're not satisfied with that service, you can't say, okay, I'm going to move to another provider, because there isn't one in your locality that meets your needs. And that opportunity to switch providers is a fundamental principle underpinning sort of market approaches to choice. And of course, providers themselves can shape the ways in which people exercise choice. They can say, well, we're not going to accept people who are expensive, difficult, cause us problems, reduce our profits. The notion of cream skimming, only accepting people whose needs can be easily met, and leaving aside people perhaps who have more difficult and complex needs to meet. We were also concerned that disabled people themselves may bring to choices some really difficult challenges. So very often with disabilities, there's a great deal of uncertainty. Things change. Something happens to you, a big change in your life, like a stroke that leaves you with disabilities. That's a huge change. You don't know what life is going to be like, 6 months down the line, let alone 5 years down the line. A lot of conditions that people experience are deteriorating. People get worse gradually over time, or conditions fluctuate. You can have good days and bad days. You need a lot more support on a bad day than you do on a good day. How do you make choices in those circumstances? We often experience illness and pain and other kinds of distress, and those may affect our ability to make so-called rational choices. There are questions as well about the roles of carers and families. Whose choices are we talking about? Are we just talking about, the individual disabled consumer, or to what extent should we also be taking account of all the families and networks that support people? And to what extent are disabled people willing to take on some of those new responsibilities? It's not just about rights, but it's also about responsibilities. Responsibilities perhaps for managing a budget, responsibilities for making the right choices, responsibilities for ensuring that the choices that you make actually maximize your well-being, actually improve your situation. So those are some problems, and those kinds of problems led us to set up a very big, longitudinal study. And when I say longitudinal, I mean a study that carried on over 3-4 years and involved repeated interviews and contacts with the same group of people. We were really lucky. We had funding from the English Department of Health for 5 years, and it enabled us to plan this long-term study, rather than most research projects. You have an opportunity to go and talk to somebody once, and it's a short-term project. But we had 5 years. We were very lucky. What we did was to set up a study where we aimed to look at the realities of disabled people making choices about the support and the services that they received in the context of changing circumstances. So we knew that people's circumstances, their health, and so on, changed over time. How do people cope with choices in those situations? We wanted to find out about what prompted people to make choices, about the processes they went through in making choices. Where did they get information from? Who helped them? What roles did other people play? And what were the broader kind of social contexts? How did families and friends fit into those choices and decisions? Really important, I think, as part of the longitudinal aspect of this study, we wanted to go back and talk to people about the outcomes and the consequences of the choices. So was it, in retrospect, was it the right choice? Did it have consequences that you didn't anticipate? And how robust was that choice in terms of lasting over time? As your circumstances changed further, your health changed further, did you need to remake those choices? Or were people able to make choices that lasted over a period of time? We had 4 groups of people in the study. We had a group of young people aged 13 to 21 who all had deteriorating conditions. Many of them had muscular dystrophy, Duchenne muscular dystrophy, but we also had young people with metabolic disorders, and some of those people had profound learning disabilities as well as physical disabilities. It also included their parents. We had a sample of adults and older people who had fluctuating health. So people with problems like multiple sclerosis, digestive complaints, lung disorders, and heart problems that fluctuated over time. And we had a group of adults and older people who'd suddenly become disabled, had suddenly, for example, had a stroke or a severe accident that had left them with a disability, because we thought that their experiences might be very different from each other. We talked to each of the participants 3 times, about once a year, over 3 years. People who had communication impairments, we used a technique called talking mats, which is a technique that was developed to communicate with people with dementia. And it uses symbols and pictures to help people to build up pictures of people's lives. We asked people to tell us about recent choices that they'd made, and we went into a lot of depth about those choices. There were a range of choices that people talked to us about. Some were about social care support, some were about employment, some were about housing, some were about major health decisions, deciding to have operations and so on. We asked them in the second and third interviews, we asked them to look back. How was that choice? How did it work out in practice? Was there anything you regretted? Anything you think you should have done differently? How well do you think the choice is serving you now? And we asked people to anticipate into the future choices that they expected to be making, to have to make as their circumstances change further. We had 3 groups of service users, and these are groups that within our research unit, they're kind of permanent consultation groups, and we talked to each of these groups about the study as it progressed. We have one group of adults, disabled adults, older people and their carers. We have one group of young people with disabilities, sort of late teenager sort of 16 to 20-ish age group, and we have a group of parents of disabled children. And each of those three groups were involved at different times in the study in giving us advice. So, something about the findings now. Making choices. Choice is not a simple, single event. Choices take place over a long period of time. It was very difficult for people to say, yes, this was a choice I made. You might make a choice, but it then may take you months, perhaps a year or more, to actually achieve what you've chosen. And the very good example here was some of the young people who were making decisions about what they did after school. They wanted to go away to college or university. That raised very big questions about how their needs for support would be met while they were away. And parents often started and the young people often started this process perhaps a year ahead, finding out which colleges and universities had facilities for disabled students, how they could get funding to provide support for the young person while they were away. So it was a and some of those processes, some of that involved some major battles with the authorities about getting the appropriate funding and facilities to allow the young person to actually experience the choice of going to the university that they wanted to. Sometimes choices had to be revised repeatedly, particularly housing. People deciding to make adaptations to their housing and having to revise plans and add on extra facilities as their condition changed over time. So choice is not a single event, it's a process. Some people said to us, well, what is choice? I don't feel I have any options. I've been presented with one option here, and my choice is I take it or leave it, because that's all there is. Is that choice? Other people talked to us about choices that they had been forced to make. Their condition had deteriorated, their circumstances had changed. They did not want to have to make a choice, but a choice had been forced upon them by changes in their circumstances. Some people wanted to avoid choice for quite a long time. So, for example, choices about surgery, choices about surgical interventions. Some people didn't want those. They wanted to postpone that kind of choice for as long as possible, particularly where having an operation meant that you had got worse. If you'd got, your condition had deteriorated to the extent that you had to have surgery, people really did not want to make that choice because, it meant that it was a marker of their deterioration. Some choices were very risky. Again, major surgery, moving house, all of those present great unknowns. You don't know how it's going to work out. And people were very anxious about all of the unknowns and the risks in making choices. On the other hand, people, and particularly some of the participants in the study, learnt. They learnt from making choices, and they were able to use their past experiences to help them make new choices. They were able to draw on those past experiences of choice. On the whole, people had few regrets. We asked them, do you regret the choice that you've made? And most people said that their satisfaction increased over time. For example, if they had an operation, and it might take 6 months for the benefits of that to be experienced, the benefits in their health to be experienced. So it took a while for people to realize and become convinced that, yes, they had made the right choice. We expected that the different groups of people in the study would have different experiences of making choices, but in fact those differences were less than we had expected. People who had suddenly become disabled, for example, after an accident or a stroke, certainly had less opportunity to build up their own knowledge and their own expertise in making choices. They had less opportunity to become kind of expert choice makers. On the other hand, they were more likely, because they had just had a major accident or other kind of trauma, they were more likely to have access to information. They were more likely to be in touch with professionals. And those professionals were very helpful in providing information and encouraging people to make choices. People who had fluctuating conditions sometimes had relatively little contact with professionals on a day-to-day basis, apart from, for example, routine medical appointments. Where they did have routine professional contact with professionals, they really valued that. They really valued the continuity of having a relationship with somebody who maybe they saw every 6 months and they could talk through how their condition had changed. Because it was sometimes very difficult for people with fluctuating conditions to realize that they might now be eligible for a new service, or that it was legitimate to start asking for support. So they needed that contact with professionals to help them, to act as a kind of prompt to start asking for new kinds of help. Information is absolutely crucial in effective choices. It's a precondition for having choice. But we found that information was also important at an earlier stage. It wasn't just that, you've got a choice to make and you need to go out there and find the information about what's available. People often needed information to know that they could make a choice, that a choice was possible in the first place. And this is particularly where people didn't realize that as their condition changed, they might be becoming eligible for services. And so having that information that actually there is a choice to be made here was really important. People often used multiple sources of information. They used the internet, they talked to other people, they used books, leaflets, and so on. But one of the sources of information that was really important was actually having experience of something themselves. So again, using the example of the young people making choices about which university I go to, what was really important there was actually being able to go on visits, seeing how easily it was to get your wheelchair through the doors and up the ramps and so on. How far was it from, the halls of residence, the adapted halls of residence, to the lecture theatres? That kind of experience was a really important source of information. People wanted information that was kind of personalised to them, that was translated into their own terms, and information from peers, from people who'd gone through similar experiences, was very, very valuable there. And trust in the person who's giving you the information. So the notion that a service provider might be trying to sell their service to you, push their service at you, was not trusted. Information had to be from impartial sources. I said earlier that choices were very risky, and there was a lot of emotion involved in making choices. And I think, again, this is something that policymakers sometimes do not realize. It's not just a benefit. Choice provides us with enjoyable benefits of autonomy, but there are negative emotions as well. And people talk to us about stress, anxiety, their feeling of being out of control because the outcomes of choices were up to somebody else to decide, and that choice was a burden. And this was particularly where the outcomes were uncertain. People also sometimes found themselves having to make choices to very tight deadlines, and that was really, really stressful as well. It's very difficult making choices when people are in poor health. People said to us they knew that when they were in pain, they were having a bad day, that they were less rational. They didn't make choices in the same kind of way. people were reluctant to revisit choices and revise them. And again, that partly reflects the fact that it was sometimes quite a negative experience. But as I said, people became gradually more and more satisfied with the outcomes of their choices over time. And of course, they learnt where they were satisfied, they learnt from that choice and were able to take that experience through and apply that experience in future situations. People were far from the kind of theoretical idea of the kind of individualized consumer making a choice on your own, about your own circumstances. Other people, friends, family, professionals, people who were trusted were really important. They acted as sounding boards. People said, no, ultimately it's my decision, it's my choice. But I couldn't have done it without having my partner, the social worker, my son, my daughter, my parents to sound as a sounding board, to talk things through. But it was also the fact that people didn't just make choices about themselves, but they took other people into account in making choices. So, for example, they would make a choice about having an operation because they knew that that would mean they could get better, quicker, and be able to look after their grandchildren. Or, you know, they would have make a choice about a particular sort of service because it would enable them to look after their own children. So other people were taken into account in making the choices. I think I'll skip the next section because I'm running out of time, and I will just talk a little bit about the policy and practice implications. Choices are difficult when your health is poor, when life is a struggle, when you get tired easily, when you're in pain, when you're experiencing psychological or other kinds of distress. Choice is difficult. And I think the evidence from our study about some of the negative experiences, the negative emotions involved, mean that we do have to be very careful about expecting disabled people to be really positive and enthusiastic about making choices. Some people have major disadvantages in making their ability and capacity to make choices. People who are isolated, people who have few social contacts, don't have extensive networks of friends and relatives, don't have relatives who work in or know people who work in influential positions. Just things like, you know, having a niece who is a secretary to a hospital consultant, having a daughter who works in the local social services office. All of those kinds of contacts are incredibly helpful in making choices. But if you're relatively isolated and you don't have those kinds of networks, you don't have family and friends around to act as sounding boards, then you are disadvantaged in making choices. People who are not eligible for public services are also disadvantaged because they tend not to be able to access sources of information. They won't be in regular contact with professionals and they will not therefore come across information that might help them realize that there are choices to be made. I've emphasized the importance of continuity, the continuous relationships with professionals, and particularly where people's health changes or is gradually deteriorating, and that regular contact is incredibly important. Contact with peers, other people in similar situations, is also incredibly important in choice making. And again, the young people in our study really brought this home to us, being able to talk to other people who had had similar experiences, made similar choices around health, around operations, around going to college. That was really important. And I think there's a message there for professionals about how far professionals encourage and facilitate that peer-to-peer contact which is very important. And I think it's also important for professionals to realise that choices are not individual experiences. They're not something that, you know, an individual consumer does. Choices are made in social contexts. They're made with families and friends and other people, and they take the choices that individuals make, take those other people into account. If you want more details of the study, we've put some of the final reports and summaries of our report on our website. So, thank you.